Hello, sir. I'm Dr. Sangam Pal. Uh, Today, I'll be sharing a swallowing study of a patient. So, this is two types of food I have taken. This is liquid, blue color liquid, and also I have taken blue color semi-solid. This biscuit and milk. And this is a patient who had a stroke 5 years back and has aphasia. He's not able to speak anything, but his speech understanding and intelligence is preserved. He is not able to he is not able to swallow things, solids, liquid he can swallow. So uh, we are passing the scope through right nose and preferably most of the time preferably after anesthesia and decongestion. And as we know, fees is like 4S. 4S is structural anatomy, sensory testing, secretion, and swallowability. So first thing is structural anatomy. So in structural anatomy, first we see the anatomy of palate, and by saying P, patient will elevate the palate. After palatal anatomy, we see the vallecula, epiglottis, vocal cord anatomy, vocal cord movement, arytenoid anatomy, and piriform sinus, false cord, and see movement of these structures. And as we know, the loss of vocal cord movement will have increased risk of aspiration. And then we see the second aspect, that is sensory testing. We can touch the pharyngeal or laryngeal structures, and while touching the laryngeal structure, there'll be reflex vocal cord adduction, and touching the pharyngeal structure, there'll be gag reflex. So either we can mechanically lightly touch using endoscope, like we are doing now. So there was reflex vocal cord adduction, or we can insufflate puff of air, calibrated puff of air. So again, we'll try to touch the arytenoid and see what happens. So there is reflex vocal cord adduction. So two things we did, we saw the structural anatomy and we sensory testing had been done. Now we should see the secretions. So secretion is level of secretion. We try to grade in three gradings according to Donzelli and colleagues. The grade one, when there is no penetration, I've simplified it. Grade two, when there is no aspiration, and grade three, when there is aspiration. So after secretions, we give patient food and see his swallow ability. We give two kinds of food, liquid. We in this patient we have given liquid and solids. So uh, this is blue colored as we saw. So we will see three aspect. So this is first pre-swallow. The bolus is passing through vallecula to piriform sinus. It is not going inside the laryngeal inlet. And then there'll be swallowing, that is laryngeal elevation, and we call this as white out. And after that, there'll be post swallow. We have to see how much residue is left. So there are minimum residue in for liquid. Again, we'll see for this liquid. So this liquid is going, this is pre-swallow study that was white out, and then this is post-swallow residue. So minimum residue is there. And so this patient's uh, swallowing for liquid is okay. Little bit penetration may be there, but then definitely there is no aspiration, and see little bit of uh, fluid has gone, but then he cleared it out by coughing maybe. So after this liquid we have given patient, so again this pre-swallow, the liquid has gone but no aspiration. We can see now there'll be swallowing and white out. It is accumulated in piriform sinus. The liquid has accumulated. Now he will swallow. Now he should swallow. So that was white out and the liquid has gone inside the esophagus, and minimum pharyngeal residue is there. Again, in 1-2 attempt, the whole amount of liquid will be swallowed. So that's why he does not have much difficulty in swallowing. So there was little bit penetration. So we can see little bit penetration, so little bit blue liquid over the vocal cord, but then he is not aspirating that. He will cough it out and it will come out. See, little bit liquid is there on the vocal cord. So this is the liquid has gone above the vocal cord. So he just brought it out, and next swallow it has gone. It has cleared. So he is not aspirating. He is able to swallow that. But after this, when we gave patient solid food, he kept all the time that solid inside the mouth. The solid get dissolved in saliva and it came in oropharynx, but then he was not swallowing it. So uh, we could not assess the oral cavity uh, oral phase of swallowing by fees. So maybe this patient will require modified barium swallow to know the reason for swallowing difficulty in oral phase. So other indication of modified barium swallow is hyolaryngeal elevation problems and esophageal dysfunction. And in fees, when there is a tracheostomy present, uh, we must tracheostomy present, we must pass our scope through tracheostome and see the subglottis to know more information about the aspiration. Thank you very much, sir. Thank you very much, sir. And this patient I'll be doing modified barium swallow as well, and then we'll see what he has. And after doing fees, we should try to diagnose the patient and develop strategies to counter it. And that also we can assess on while doing fees. Thank you, sir.